A lot of from not being able to do so, but I'll pass the floor to Soumya, who's got a much closer perspective on the situation in India than I would.
I think, Mike, you covered, of course, India with a population of over 1.3 billion. The numbers that we see now, which are over 200,000, big, but for a country of this size, it's still modest. I think the important thing is to really keep track of the growth rate, the doubling time of the virus, and make sure that that doesn't get worse. And also, because it's such a heterogeneous and huge country with very densely populated cities to rural areas where the densities is much lower, and also with the health systems being different in different states, with all of these offer challenges to the control of COVID. I think what's been happening with the expansion of testing, tracking, making sure that contact tracing is done, making sure that clusters are identified and dealt with, particularly in the overpopulated, very dense urban settlements in the low-income gatherings do not happen, because these are really the situations where the spread can happen and you can get these high transmission events. And also, as the lockdown is lifted and as the restrictions are lifted, to ensure that in all aspects of life, precautions are taken, that people understand. And I think we have been making this point that really, if you want behavior change at a large level, people need to understand the rationale for asking them to do certain things. We're talking about the wearing of masks. I think in many urban areas in India, it's impossible to maintain physical distancing, and therefore important that people wear appropriate face coverings when they're out and about. Also in office settings where physical distancing cannot be maintained, in transport, in educational institutions, as some states are thinking about opening. I think every institution, organization, industry, and sector needs to think about what are the measures that need to be put in place before you can allow a functioning. And it may never be back wherever possible, that if people can work from home, there are certain professions where you can work from home, that could be encouraged. But of course, there are many professions where people have to go to work, and you need to put in place measures which allow them to themselves, to make it easier for people to both protect themselves and protect others. And I think communication and behavior change is a very large part of this whole exercise. And I don't know if Maria, you want to add more to that?
Yeah. By the way, one thing I would like to add is, of course, COVID, it's very unfortunate, and it's challenging many nations. But we need to look for opportunities too. For instance, for India, this could be an opportunity to speed up Ayushman Bharat, especially with a focus on primary. Very strong commitment from the government to speed up the implementation of Ayushman Bharat. And with primary health care and community engagement, I think we can really turn. Using and speeding up what has started could actually help in India. And that's what WHO was very appreciative, by the way, when Ayushman Bharat started. And this could be that and speed up and use it to really fight this pandemic.
Thank you very much. Let's try to take one or two questions more. And I would like to thank Dr. Swaminathan, who was speaking from a different chair. We have lots of guests, so we had to sort of change places during this press briefing. Helen Bransfeld. Helen, please go ahead.
Hi, thanks very much for taking my question. I was wondering if Maria or some of the people from the infection control and prevention team team could answer this question for me, please. We see a lot of studies come out that talk about long-term shedding from the throat or nasal passages by PCR, and people concluding from that people remain infectious long after recovery. But I think very few have actually done viral isolation. What do we know about how long people shed infection, please?
So thanks, Helen, for this this very important question and very specific question that is so important for our understanding of mission. As you say, there are a number of studies that have been published that look at how long positive, and these are the results of tests. These are tests from individuals. What we know is that mild patients, people with mild infection that don't require hospitalization necessarily, can be PCR positive for 2, and there are a number of studies from the time of symptom onset, can be PCR positive for 3 weeks or so. We know that people who have severe disease, who end up in hospital, can be PCR positive for much longer, for weeks and weeks, and I don't have the upper bound of that. Studies have now looked at trying to isolate virus from patients. And the reason that that is important is because when you do a PCR test, you're measuring the fragments of the RNA, the fragments of the virus. And that's important, and there could be different viral loads, but we don't relate to in terms of infectiousness, if somebody can actually pass the virus. And that research is ongoing. There have been a few studies that have tried to isolate virus. There's one study that was published in Germany. There's a study from, I don't know if that one's published yet, and a few others that have attempted to isolate virus. And from what we know from that is that individuals who are on the more mild end of the spectrum, from the time of symptom onset, virus can be isolated up to 8 or 9 days. The 10th day or so, they are not able to isolate virus. So that gives us some clues about when a person may be more infectious, may be able to transmit to others. That doesn't necessarily demonstrate that someone can pass the virus to another person, but that's important. Some unpublished data from another country, from a high-quality lab that followed severely ill patients that were hospitalized, and they attempted to isolate virus from severely ill patients, and they found virus up to 3 weeks. So these patients are in hospital, they are already isolated, but they're able to isolate virus up to 3 weeks. So this is, again, another evolving field where we need more information. WHO has recently discharged criteria for isolation, and actually that was released in our clinical guide. We have a scientific brief coming out with more detail on that, hopefully today, but probably over the weekend, which articulates the evidence around this. And so our new criteria for discharge for isolation is 10 days from symptomatic patients plus an additional 3 days of symptom recovery, meaning that they don't have their symptoms, including fever and respiratory disease. We also are aware that asymptomatic cases, so people that are PCR positive, can also be positive for up a week or so. But again, we need more data to be able to characterize that well. And so for the discharge criteria for isolation of 10 days from the time of the positive case. So Helen, I'm sorry, it's a long answer because the data is still coming out. But making that someone that is PCR positive, especially after they have recovered, it's not likely that they are still infectious. But we are working with many partners to better understand this area.
Thank you very much, Dr. Van Kerkhove. So we'll go to last question for tonight as we're approaching. So we have Ana Pinto with us from Folha de Sao Paulo de Brazil. Ana, unmute yourself, please.
Yes, can you hear me?
Yes.
Okay, I have a question. Not hydroxychloroquine, but chloroquine. It was one of the drugs selected to be tested within the Solidarity trial, but the trial was pursued only hydroxychloroquine. And last week, chloroquine was removed from the list of potential drugs on the Solidarity trial website. I'd like to know why chloroquine has not been tested, and if it is excluded and for all, or if it may. Thank you so much.
Thank you for that question. So at the beginning, when the committee was looking at what drugs to put into the hydroxychloroquine and chloroquine were both considered. But looking at both the efficacy and the safety profile of both the drugs and the potential to have more benefit, hydroxychloroquine was selected. So I think the urgence of the protocol said hydroxychloroquine or chloroquine, but as a matter of fact, the protocol that enrolling in many countries only had hydroxychloroquine. And some of action you would expect similar efficacy. Chloroquine did seem to have an edge based on some of the laboratory studies. And so the experts recommended that that be prioritized. And so the later versions of the protocol do not have that. So no country actually started using chloroquine. It was only hydroxychloroquine.
I understand before we finish that Dr. Van Kerkhove wanted to clarify one point.
Yes, thank you. Sorry, I've received several texts to try to clarify our position on coming out in the guidance, and you'll see the full guidance. So just very briefly, to reiterate, as said in his speech, and I encourage you to read the full speech and our guidance, we recommend are used as part of a comprehensive package, which includes a variety of things, including that people who are sick are at home, suspect cases are tested, and confirmed cases are isolated and cared for, contacts are identified and traced and quarantined. In our guidance, what we recommend for healthcare workers who are caring for patients who are suspect or confirmed COVID-19, that they follow droplet and contact precautions, which includes the use of a medical mask, in addition to other PPE such as gowns, eye protections, and gloves. We also recommend for healthcare workers when they are performing aerosol generating vicinity of where these aerosol generating procedures are conducted to use airborne precautions, and that includes the use of a respirator. What is new in the guidance that we're putting out is in areas of community transmission, in areas of clinical care, that the workers continuously wear a medical mask throughout their shift. So that is something that is in addition to the guidance that we have put out previously. For the general public, WHO has recommended that the general public, if you're sick, of course you should be at home, but if you are unwell, you wear a medical mask. People who are caring for you also wear a medical mask. And what is new in the guidance that's coming out today is that we provide specific examples of situations in community transmission where physical distancing, in particular where physical distancing cannot be achieved, cannot be maintained, that a non-medical mask, a fabric mask, should be used. And what we have in the guidance is materials and how to actually compose that fabric mask. And that comes from new research that we've requested from our partners to be able to say how many layers, what types of materials, and there's a lot of detail in here about the filtration efficiency and whatnot. But I want to reiterate that this is in areas where you have active transmission and in particular where you can't do physical distancing. So like public transportation or in some closed settings, and that's important. But as Mike has said, and as I have said, and as the DG has said, we since have been supporting governments, supporting decision-making, a risk-based approach on where and how and what type of masks can be used, because it is very context-specific. And so we hope that the guidance that comes out clarifies some of these positions. We're always happy to take more questions if anything is unclear, but I just wanted to add that. So thanks, Tarek.
Thanks, and obviously, as Maria said, if you have more questions on this important topic, don't hesitate to contact the media team, and we will put you in touch with one of our speakers who have been with us tonight. With this, I will conclude this press briefing. The audio file will be sent to you shortly, and transcript will be posted, hopefully, tomorrow. And I wish everyone a very nice evening and good weekend.
Thank you, Tariq, and thank you for joining us. And